Hello and welcome to This is 65. I really appreciate you joining me today, and I am so excited to introduce today's guest. We have on by special treat Mark Hagland. He's a nationally recognized journalist and speaker in the healthcare space. For 15 years, he served as editor-in-chief of Healthcare Innovation and has over 30 years of experience as a healthcare journalist. He's literally written on every non-clinical topic out there in healthcare, anything ranging from healthcare policy to operational innovations. He has been honored with numerous awards for his writing. He's a dynamic speaker and an accomplished author, co-authoring Paradox and Imperatives in Healthcare, and also authored Transformative Quality over his career. We recently connected and explored the world of Medicare, the A, B, C's, and D's of Medicare, and really how to close the gaps in those coverage. And through those discussions, we noticed that there's a lot of information or misinformation out there about Medicare Advantage plans. And I wanted to invite Mark onto the show so that he could provide his unique perspective on Medicare Advantage in the healthcare space after his years and years of experience. So welcome to the show, everybody. Mark Hagland. Welcome, Mark.
Thank you so much, Erin. It's great to be with you. Thank you for inviting me.
You got it. Thanks so much for joining and making time in your busy schedule. I appreciate it. And I'm really excited to hear and share some of your insights with my audience. I know that your time is valuable. You do speaking arrangements throughout the country, and you made some time for us on This is 65. So thank you so much.
Absolutely.
All right. Well, so tell us all about you, Mark. What's your background? What's your story? How did you get into journalism? What's the 50-cent tour? Tell us everything.
Well, I got a master's degree in journalism from the Medill School of Journalism at Northwestern University, and I worked on a couple of magazines. And then in 1989, I answered a blind post office box ad in the Chicago Tribune looking for a journalist, and I ended up at a state medical society as my first job, managing a magazine for physicians. So that was 37 years ago, and I've been a healthcare journalist since then. I've been at a number of different publications. I've spoken a lot in healthcare, and as you briefly mentioned, I've kind of covered everything non-clinical. I've never written about strictly clinical issues, but I've covered policy, operational issues, payer-provider issues, healthcare IT issues for a long time, and it's been very exciting. And it was so interesting to connect with you about Medicare Advantage options because I've been writing about Medicare Advantage. So it's a fascinating perspective to have been a journalist in a certain area and now to actually be a participant in terms of being a beneficiary.
Right. It really is a whole nother angle. And I can't wait to get into that with you, right, as we uncover the hood, so to speak, on Medicare Advantage today. But before I do, take me back for a minute, 37 years ago, right? So you get that first gig. How did you get hooked? Like, what was it that drew you in, and why did you like it so much?
Well, and you know what? And yes, in those days I did have hair. And
I hope it wasn't the healthcare writing that did this to you.
Right. No, it was life, but I did have hair when I started out. But here's the thing, Erin, and I know you know this. Healthcare is absolutely fascinating. I mean, it's endlessly fascinating. I literally learn something new every day. And that I describe myself as an intellectual complexity junkie. And there's nothing more intellectually complex than healthcare policy.
You found your calling, 100%. Yeah,
exactly. And from the first, I was absolutely hooked, as you said, about being hooked. It just is fascinating. Healthcare, first of all, it touches every single one of us. Every single human being has health or a lack of it, sadly, and needs healthcare at some point. When I started, I was quite young. It wasn't going to the doctor regularly, but I knew I would need regular healthcare at some point. And one of the things that fascinates me is the issues that we deal with they're life-changing, and people need access to good healthcare, and they need quality healthcare. They need to know that it's reliable. They need to be able to understand what quality is, like how to evaluate a physician,
how to
measure it. Yeah, exactly. And then you get to the federal and state levels, and it's just immense complexity. how do policy leaders decide what should happen?
Yeah.
How should people be able to access healthcare? Who should pay for what? What should be paid for? What shouldn't be paid for? And our society is changing. We're getting older. I mean, I like to say I'm aging faster than anyone, but the two main, I don't know if you know this, but there's a group inside the Centers for Medicare and Medicaid Services, CMS, called the Medicare Actuary Group. So actuaries, of
Mhm.
course, they look at statistics and
Punching the
figures.
numbers, right?
Yeah, yeah. And every year they do something that's tremendously important. They release figures on total US healthcare expenditures, meaning everything that we spend on healthcare. And our numbers are just exploding now. We're going from the current $5.6 trillion a year, which is already completely mind blowing,
Right.
and 17 plus percent of GDP. We're going up to 8.5 trillion by 2033, and it's going to be 20% of GDP, which is completely mind blowing. And the challenge is that the fundamental issue, the aging of the population, there's nothing we can do about that, right? The
Right.
US population is aging, the European population is aging, the Asian population, everybody's aging. So society, the advanced societies are all having to deal with that. And then on top of it, here in the US, we have a worse explosion of chronic illness than any other country right now that we know of.
Right.
So you combine those two things, and that's why things are exploding. And even with all the conditions and limits we place on healthcare access, it's still exploding. So part of the fascination is the almost insoluble problem: how do we fix all this? And
Right.
because we kind of can't afford the healthcare system we have now, and now imagine 51% more expensive in
It's
several
insane.
years. Yeah.
Yeah. You have a lot of passion, Mark. I mean, that comes shining through. It kind of blows me away how passionate you are and how invested you are in what you're doing. And you combine passion with a lot of knowledge, which you clearly have. Um, what do you think is going to happen? I mean, with this, doubling down on costs, it's like 51% higher. Like, what do you predict? How do we combat this?
I think things are just going to get harder. We no one, well, let's put it this way. I don't know of anyone who doesn't want people to have any access to healthcare,
Of
right?
course. Right.
So, given that a fundamental principle is that people should have access, they should have fair access to good quality healthcare. We're just going to have to do everything we can. And one of the things that I've been covering for many years now is what happens inside the healthcare system, especially inside hospitals, medical groups, health systems, health plans. Um, what we're doing now is there's a movement toward what's called value-based care
Hmm.
delivery and contracting, where it's pay for performance, and more providers, meaning hospitals, doctors, etc., are having to prove that they're making people healthier, not
Right.
just not just the old fee-for-service
We see
way.
that reflected in everything, even the
Yeah,
star ratings and so forth. So
exactly.
definitely a focus there. Yeah.
Yeah, that's exactly it. So I
Do you
think we'll
think
get
that's
more
working?
intensely into
Do you
that.
think that's working, Mark? Is that
I
like it's
I
a
think
step in
it's
the right
I think
direction?
it's working, but we're still very early days. We really
Right.
are. It's fascinating to interview people in medical groups, hospitals, and health systems that are on the leading edge, because they're working very hard to keep people healthier. But
Right.
it's complicated. We could talk for hours about how they're doing it, but it's
Right.
complicated. If you have, as I like to say, first of all, it's fascinating. Did you know that millions of people have four chronic illnesses, which is just astonishing, but they're living with
It,
four.
it is. It is astonishing. And it's
Yeah,
crazy just to see how many pills people are taking
yeah, yeah,
associated with those chronic illnesses.
yeah. So here's a typical combination of multiple chronic illnesses: congestive heart failure, diabetes, COPD, which is lung disease, and coronary artery disease, and high blood pressure. Wow, it's a lot, right? So what they're doing now is they're far more involved with the patient, with the consumer, on a week-to-week basis than used to be. Under the old fee-for-service medicine, it was really a sick care system, and you go in and you get sicker and you get sicker, and then you go into the emergency department, you go to the hospital. Now they're trying to prevent hospitalization. That's one of the key things they're doing. Obviously, there are times when a person must be hospitalized, but they're trying to what they call avert unnecessary hospitalization. So those are some of the areas, and they're working with the people with the multiple chronic illnesses or whose chronic illnesses are very intense, because that's about 5% of the population, and the care that is being devoted to them is accounting for 15 to 20% of the cost.
Wow, it's unbelievable. Right. Yeah. If you make a dent there, you're really helping lift the whole bubble. When I think about what you're saying there, what it sparked for me was thinking about how Medicare Advantage plans play significantly in this space, like of comorbidities, I guess we'll say, having the diabetes in the heart or whatever the combinations of, God forbid, 4 of them, right? Yeah. And a lot of the financial arrangements between health plans and CMS, or health plans and Medicare, center around these comorbidities. And so their ability to code these illnesses or to put people into special plans with a model of care, there's a real focus on that. Can you touch on those types of plans? And is that working? And is this a good idea?
It is. And here's a great thing about Medicare Advantage. The government is paying these health plans to engage in care management. That's the bottom line. Traditional Medicare doesn't have care management. You're basically on your own. There's a stereotype that's talked about a lot in healthcare among providers, the little old lady carrying a shopping bag with 30 medications in it, right? And she is essentially care managing herself. Well, that doesn't work very well. So here's what's really interesting. We have now gone over 50%. 54% of all Medicare beneficiaries are now in Medicare Advantage plans. That's 34.1 million people. In 2007, it was just 19%. So it's really, and most plans offer benefits like vision, dental, and hearing. Those are very important too. Those keep people vital and able to live full lives. In fact, 7.2 million people are involved in what are called special needs plans. So one of the great advantages of Medicare Advantage is that the health plans are being rewarded by the federal government for caring for people. And that's kind of where the whole healthcare system is going. So it really aligns with this idea of value-based care delivery and contracting, and with this idea that the only way we can make inroads into this just exploding, if you did a fever graph, the line of healthcare costs is going like this, right? And the only way to deal with that is to get involved in intense care management, also measurement of quality, things like that. If we just did none of that, our costs would just completely explode, and it would get to the point of almost unaffordability. There was a famous healthcare economist years ago named Uwe Reinhardt, and he used to joke when he did presentations. He would show a chart that showed 100% of GDP for healthcare. Well, obviously that can't happen. We have to buy clothes and cars. We have to eat. There are things that aren't healthcare. But at the time that he was saying that, Uwe Reinhardt's heyday was in the 1990s, we were at 12% of GDP spent on healthcare. And people said, well, we could never go over 16%. We're now at 18%, going to 20%.
Right. And heading way up, right? Heading that direction.
Yeah.
I have a question for you, Mark. So I know I work really closely with many Medicare Advantage organizations in my space, right? So in a different angle, helping people actually get the product and get involved. And I see a lot of different tactics that Advantage plans do to get the proper coding and model of care in place for patients. Things like health risk assessments, things like working with providers to do chart coding and feeding that data to CMS. What would you say to the average Medicare beneficiary out there that's like, hey, I feel uncomfortable providing this information, or, I'm not sure I want to do it? What words of encouragement would you provide in terms of where this looks forward thinking?
Well, Medicare beneficiaries don't have to worry about privacy. They've built privacy into the system. And when they do all the numbers crunching, it's based on huge amounts of data. It's not someone is looking at Aaron's numbers, right?
Right.
That's not their focus. And it doesn't go into anything around care access. If you're in a Medicare Advantage plan, you get the care, right? Based on the policies of the plan. They're not going to cut your care or benefits based on health outcomes or health status data. What they want the data for is they need to see the trend lines, right? Which is exactly how we're seeing where we're going right now. How do we know that we're going up to 8.5 trillion a year in healthcare expenditures? It's based on crunching numbers just like super intensively, numbers of what's happening right now. In other words, they're looking at utilization right now and they're saying, oh gosh, this is where we are right now. And then we project forward the people who are 71 years old now. 8 years from now, they'll be 79. How much more healthcare will they need? So you don't have to worry about privacy issues. And ultimately, they're taking data to help us because this also reinforces the care management. It's what, on a policy level, convinces policy leaders like members of Congress to say, oh, yes, Medicare Advantage is a good thing. People should be in it because it's doing these things. It's doing the care management, the population health management, the quality measurement.
Yeah. So, and you're no stranger to this being in this field, but Medicare Advantage plans get very mixed reviews, let's put it that way. Right. And so, you quoted a statistic, 54% of people nationwide on Medicare are on a Medicare Advantage plan. And I think I read somewhere like something like 2/3 of those are on a plan with no premium at all. That's giving them dental, vision, hearing, and all these bonus perks. So there's a interest in Advantage plans, regardless of what we hear in the media and how the plans are portrayed. But when you look at the big picture, outsider looking in to a space that very, very well, what are your thoughts about Medicare Advantage as it compares to original Medicare? Like, what are the pros and cons? And, what are your thoughts about Medicare Advantage for a person trying to make that choice?
Well, first of all, on a very basic practical level, to be in a no premium plan is a wonderful thing, right? So there's that.
Absolutely.
But I also think that, the reality is more and more and more of us will have chronic illnesses. We'll be living with chronic illness. It's really good to be in a plan. That's where you're going to get the care management. You're going to get the extra attention from doctors and nurses. People will be watching out for you.
Right.
I remember in 1997, so yes, it's a long time ago, nearly 30 years ago, I was freelancing and I was writing for a magazine that went to physicians in California. And they asked me to do a cover story on what was then called disease management. We now call it care management for the most part. And I went to 3 clinics. I went to a congestive heart failure clinic. I went to a dialysis clinic, and I went to a clinic for COPD, people with lung disease. Wow. I really felt for the patients. They allowed me in exam rooms. Of course, I couldn't name the patient or take pictures.
Right, of course, yeah.
Just to observe the physicians with the patients. And like I said earlier, there are people living with COPD, CHF, and diabetes all at once. And it's very tough. They have very difficult lives.
Right.
And one of the things that was interesting to me was that was very early on in the disease management, population health management, care management movement. And the congestive heart failure clinic I went to was run by 3 harried nurses and 1 cardiologist. and it was really fascinating. They were doing amazing work, but it's hard to do that when there's no scale. What we have now, we have scale. Health plans are doing it. Health systems are doing it. They're able to crunch numbers, and then they're able to apply what they've learned to Mrs. Smith, a specific patient, right? So what they'll do is, so a provider will have let's say 10,000 patients attributed to them. And then they'll say, okay, let's look at our patient population. How many people have congestive heart failure? How many have diabetes? This is the beginning. You have to do some analysis. And then they'll say, oh, look, we have, after doing a lot of numbers crunching, they'll say, oh, look, we have, I'm making these numbers up, but 8,000 patients attributed to our program with diabetes, and 4,000 have uncontrolled blood sugar, right? So what you do then is, so you start at that broad analytical level, and then you say, who are those 4,000 people? How do we get 4,000 Mrs. Smiths into our program? And that's the golden place, right? Because and then Mrs. Smith hears from a nurse every week, or maybe she gets on an app now and they're tracking her or whatever. That's where you get the progress, and it makes people healthier.
It definitely does. I mean, I've actually seen it in action. We work with a company in California called CareMore for years. They were affiliated with a broader health plan that I worked with, and the outcomes were amazing for diabetics and amputees. The dramatic reduction in amputees, it was amazing, right? And so that hands-on care management really does make a difference. And I think you bring up a great point in that we kind of knew it was happening back in 1997, but now we have better tools. We're armed with better tools to be able to do something about it.
Yeah, and we even now have AI for this, where you're applying analytics. So before the year 2000, so as I mentioned, that cover story I did was in 1997, very few physician groups and very few hospitals had electronic health records at that time. So how did they start analyzing things? They had piles and piles and piles of paper. Nurses would sit down, and can you imagine a nurse with like a stack of paper?
I can't imagine it, and it sounds really bad.
Well, I mean, think about how long it would take to do some basic analysis on paper, right? Now AI can do it for you in seconds, which is wild, right? So they're applying it, and AI is just advanced analytics. I've been writing a lot about AI, by the way, but analytics can help you as the provider in the health plan just figure things out, right? How many, like I say, we're in, for example, maybe an accountable care organization which cares for Medicare patients, and we've been assigned 10,000 patients, let's say, and we find out that 4,000 are diabetic, and we find out half those have uncontrolled blood sugar. But what you immediately do then is you figure out who those people are, you get in touch with them, and you call them up or you find them and you say, hi, Mrs. Smith, my name is Nurse Judy. And I just want to get in touch with you. We have this great program. And what it means for you is we'll be in touch with you every week, or however they design the program. We just want to make sure you're doing okay. And we want to be the people you can turn to when you have a question like, oh, wow, I've changed my diet and it hasn't worked, or something like that. That's where you get the change.
Absolutely. And that hands-on. And I would especially think, especially in the senior market, it's going to be even more relevant because there's a lot of isolation and depression. And so just having that hands-on approach is huge. So amazing work. So, Mark, you touched on something earlier, and we sort of said it in passing, but CMS, right? Yeah. And so I'm familiar with CMS from my background, and you even touched on something today that I hadn't heard about before, just the overall analytics of the healthcare space. But who is CMS? What does it stand for? What's their role? How do they influence and monitor Advantage plans?
Yeah. So CMS stands for the Centers for Medicare and Medicaid Services, everything around Medicare and Medicaid at the federal level. And then, as you know, Medicaid is actually administered at the state level. So there are two different levels there. Medicare is totally federal. What CMS does, it does a lot of different things. Crunches numbers, it makes sure people are covered by Medicare. And it's thousands of people who are trying to figure out how to make the healthcare system work better, basically. Now, there's an interesting part there. There's an element called the Center for Medicare and Medicaid Innovation, called the Innovation Center, or CMMI, two different abbreviations for them. And they're the ones rolling out new models of care. So they're very involved with Medicare Advantage. They're also involved there are a lot of what are called alternative payment models, and that that's a whole world in and of itself. There are people
Right.
who spend full time writing about this or monitoring it, but what they're trying to do right now is overall, and this encompasses Medicare Advantage, and it encompasses all these other vehicles like accountable care organizations and APMs. They're trying to figure out what works. How do we do two things? How do we halt the incredible rise, the explosion in cost, right? How do we curb the cost curve, and how do we make people healthier? How do we, as a nation, make sure that people aren't falling through the cracks? Traditional Medicare doesn't do that. It's
Right.
really a sick care insurance
Payer
system,
system. Right.
right? Yeah,
Exactly.
fee for
So,
service, and so one of the reasons the federal government, and this is, by the way, this has been true in all administrations, both Democratic and Republican, they're all trying to get as many people into some form of alternative payment model that includes Medicare Advantage, includes these other models. They're trying to get everyone out of traditional Medicare into some sort of population managed Medicare uh,
mhm.
within the next decade. And that goal actually was initiated under the last administration, but the current administration completely endorses it, and they want to do it too because of
Right.
the cost, right?
Right. Of
And
course.
and so the fundamental thing that the CMS leaders are trying to do now, and this has been true for several administrations, the different political parties, different overall ideologies, is they realize that we've got to get a handle on this, both cost wise and health outcomes wise. And so there's all this innovation going on, and Medicare Advantage is a part of it. There's a huge constant policy discussion around Medicare Advantage, and one could talk for hours about it. But the bottom line is that members of Congress understand um, that traditional Medicare just won't take us where we need to go.
Right.
Then you get into all the debates about which models to use and all that. But
Right.
traditional Medicare has to go by the boards.
Somewhere. Right. Yeah.
It's the
You
only
know,
way to get a handle
when I
on
hear you talk about Mark, like this subject is really complex,
it.
right? I
Yes.
mean, it's what you're attracted to. You taught me that early on, right? You like the complexities, but take a step back and be Mark the consumer
Yeah.
again, like but cutting through the noise and trying to pick the plan. With your expertise, if you were advising somebody who was getting new to Medicare and had to look at the systems, what were the 1, 2, 3, 4, or 5 things that you did that you would recommend for others in terms of choosing the right option?
So the funny thing is that Mark the healthcare journalist is like a completely different person from Mark the healthcare consumer. It's just
Uh-huh.
like the three faces of Eve or Sybil. But but and what I mean by that is I understood all this from a policy level, but now that I'm of the age where I've had to research this for myself personally, I still had to call friends, find out what people were doing. Here's the key, absolutely key thing. Do your own research, go online, of course, reach out to friends. I was connected to you through a wonderful friend, and figure out. And when I say do research, I mean really be thoughtful about it. Figure out what your goals are. Understand how the insurer might see your health, right? Like one of the reasons for going into a Medicare Advantage plan, if you have a chronic disease, is that someone will be watching out for you.
Right.
You also have to do research on how much your medications are going to cost. I mean, that's going to be a huge thing for people.
Big.
So I think it's just important to be educated and knowledgeable. Just do a lot of reading. There's an amazing amount out there, and you can go to publications like Consumer Reports or whatever. There are all sorts of sources out there. Just use the Google, right? And you will eventually find. Of course, go to reputable sources. Make sure you go to only reputable sources. Read reports. Understand the context of your own health situation, and then try to find reputable organizations like yours that counsel people. You guys are terrific.
Thank
Uh,
you.
yeah, and you didn't have to pay me to say that. Eh,
No
but
payments exchange hands here.
right, exactly. Okay, but find a reputable organization like yours. Talk to someone. Um, oh, and when you do that, have questions ready, right? Like all the questions you might have about what your healthcare coverage will entail going forward, not just like today, but 2 years from now, what will it look
Right.
like?
Or
Um,
if nothing's wrong, if the rubber hits the road, what would you want done? How would you want it done? All those things
exactly,
matter.
exactly. And the reality is, like I said, I was joking. I'm aging faster than anyone, but the reality is we're all aging, and you you, you as you enter a certain age, you really need to think in very concrete, refined ways about what you're going to do about your health going forward.
Right.
You can't leave it to chance. You have to make good decisions. Talk to everyone, and and like I say, once you reach an organization like yours that can help you, make sure you've researched it so you can ask good questions.
Right.
Don't just go in there saying, "Oh, just help me,"
Right, exactly. I think that's great advice. And really, I recommend people start this, on the 64th birthday, just,
Yes,
looking into it a
yeah,
little bit and just getting a feel and understanding it. Because if you leave it to the last minute, you could miss important deadlines or you might make a rush decision or those things. So I think that's great advice that you're
yeah,
providing. And of course, always
absolutely,
reach out to us at blackpointinsurance.com. We're always happy to help you as well. So thanks for the plug,
absolutely.
Mark.
Well, I'd say, no, you're all very knowledgeable. You're very thoughtful. And when you counsel individuals, you bring your knowledge and you bring your thoughtfulness and humanity to that, and it
Oh,
shows. So,
oh, thank you so much, Mark. I appreciate that. I was thinking about something you said earlier, and you kind of gave me a little mini prediction, right? You said, the goal is in 10 years, it may not be the Medicare Advantage model of care or whatever. It could be some other formula, but Medicare, original Medicare is not sustainable, fee for
yeah,
service Medicare. And so you sort of predicted in 10 years, there's a goal that it'll look a little bit different. And so I just wanted you to kind of elaborate on that a little bit. If you were to think with all your background, 5-year outlook, 10-year outlook, 20-year outlook, where do you think we go from here? Like if you were to predict, obviously you don't have a crystal ball, but what are your thoughts on that?
I think that what we're going to see in the next few years, I mean, they're already saying it, so it's not a wild prediction. The leader, they're telling us the leaders at CMS, especially at the Innovation Center, the Center for Medicare and Medicaid Innovation, they have said that what they're going to do is they're going to focus on a small number of models. They're going to keep trying different alternative payment models. Medicare Advantage will go forward, and then these other models for paying providers to care for people will also go forward. And they'll just keep analyzing them and seeing what works. There's a program called the Medicare Shared Savings Program, MSSP, which is the largest program around what's called accountable care organizations, where hospitals and doctors get together in a little bunch and they say, okay, we are now the Mark and Aaron MSSP ACO, right? And
Obviously, that would be highly successful.
yes, yes, it would be very popular. So they get together and they say we're this ACO, and then Medicare pays them, and there's a very complicated formula, like it's super complicated. But those kinds of models will also move forward because they are all predicated on hospitals and physicians looking in advance at your health, at your individual health, and trying to keep you healthy. So it'll be a combination of Medicare Advantage, accountable care organizations, and other alternative payment models. That's what CMS wants. They're saying it. So it's not like this crystal ball. It's what their plan is. So
Right.
that everyone who is covered, everyone who's a Medicare beneficiary in some form is in one of these models, is in one of these forms of payment and care delivery, because traditional Medicare is simply too expensive. Like, just to give you one tiny example, one of the things that keeps happening, people with congestive heart failure, unfortunately, it's a very serious disease, bounce back into the hospital all the time. And the Medicare people have looked at this. They've done a lot of analysis over the last 10, 15 years, and they've said, do you realize that we can avoid, you know, more than half of these
Wow.
rehospitalizations. And it has to do, again, with putting people in a care management program so that you're not bouncing back into the hospital, because to care for you over the phone or in a medical clinic, for example, costs 1/10,000th of your going into the hospital even for one
Right.
night, right?
Right.
And so the only way that we can curb this cost curve that's just exploding is, again, I'll say that, the archetypal Mrs. Smith, as they call her. Mrs. Smith has to be connected to a provider, and usually her connection is going to be a nurse case manager on a
Right.
week to week basis, right?
Right.
So, hi, I'm Judy, your nurse case manager. How are you doing this week, Mrs. Smith? Let's talk about your weight. Let's talk about your salt intake. Let's talk about fluids, things like that. And 90% of the time, when Mrs. Smith's health is worsening, they can catch it in advance if there's someone watching for it. The
Right.
people who are bouncing back into the hospital and into the ED, the emergency department, are the ones who are non-care managed, right?
Right. Makes perfect
And
sense.
yeah,
And what a better experience, right? I mean, wouldn't you
yes,
rather be the person who doesn't land in the hospital and gets to
yeah,
talk to somebody to help you manage your care better? It feels just better overall.
yeah. I mean, honestly, 99% of people don't want to be in the hospital.
Right.
They want to live their lives. They want to be at home.
Right.
A hospitals do the most amazing work in the world, but you don't really want to be in one if you don't have to,
Right.
right?
Well, and you're
It's
exposed to a lot of illnesses. I mean, there's
yes,
so many things that go with that. So,
yes, high levels
well,
of infection. So that's where we're going, and I think here's the really good news, though, Aaron. The the physicians in hospitals are learning uh, more and more techniques for this care management now, and they're allying those techniques with analytics. Everybody's analyzing. The health plans are analyzing, the providers are analyzing, everyone's analyzing. So we're getting to the point now where um, we've learned. 20 years ago, um, when I first did, now that's almost 30 years ago, when I did that disease management cover story and had hair, when I did that disease management cover story,
so many changes.
so many changes in the world, yes. But when I did that cover story, providers were just starting to figure it out. Like I
Right.
mentioned, this heart disease, this congestive heart failure clinic was run by 3 harried nurses and 1 cardiologist, kind of in their spare time. It was wild,
Right.
out of a
Right.
hospital in San Diego, and that you can't really sustain that. What they're able to do now, providers are doing this at scale, so they're
Mhm.
catching 1,000 Mrs. Smiths, not just 2,
Right.
and that's where things have to go. And I have to say, on a positive note, on an up note, the healthcare system is a learning system, and people are figuring out what works and what doesn't. And we're in a better place than we were. And on this policy level, per your question, I think we're just going to move into more and more and more care management. So practically everyone who is living with chronic disease over time is going to be in a care management program. That's where we're
Right.
headed.
Totally makes sense. I mean, I'm sort of filled with optimism doing this, Mark, and I'm thinking about you and your future. You have no more hair here to lose, but you've got other places.
Yeah,
So what's
facial
next? What's next for you, right? I mean, is it in the AI space? Is it increasing your presence on the speaker channel? Like, what do you see for your future?
Well, thank you for asking. I'm an independent journalist now, and I'm speaking, so I'm certainly open to speaking engagements. I'm writing for a variety of publications. I'm very interested in AI, and I want to say one note about AI. By the way, a lot of people are afraid of AI, and there are reasons for it. All the terrible fraudulence that's going on, like with stealing people's art images and things like that. That's bad. But what I will tell you is, in healthcare delivery, clinicians and informaticists and data scientists are using AI to figure out how to make care better. I recently did articles on AI in oncology and AI in radiology, and that's another whole discussion. It's fascinating, though. They are improving the ways in which oncologists, radiologists, and other specialists are working so that they can work better and help us better. The oncologists and radiologists are two of the specialties that are the most time pressed of all. They're just slammed, and they've got so many data, so much data, and in the case of radiologists, so many images. They're overwhelmed, and so AI is going to help them do their jobs better.
It becomes a tool in their toolbox to cut through the noise and figure it out.
So, absolutely. So that's an area I'm really fascinated by. But anyway, I'll just keep writing. I'm just going to keep writing. I'm going to keep speaking, and it's an exciting world out there because we're at the point now where some of the things that were predicted as being futuristic 10 years ago are actually happening. So it's exciting. The healthcare system has huge challenges, but you know this. There are so many smart and dedicated people in healthcare. It's incredible. It's one of the greatest joys of my career over the last 37 years has been talking to brilliant, humanistic, dedicated people who are absolutely dedicated to improving the lives of people. Isn't that the greatest thing?
100%. It's the best thing. It's why I personally love this field. It's wonderful. So I'm with you there. So Mark, if people want to get in touch with you to have you speak or to pitch a story idea or just to read more of your work, how do they best get in touch with you?
So I'm glad you've put that little note at the bottom there. They can reach me at markhagland@protonmail.com, MarkHagland @PROTONMAIL.com, or they can find me on LinkedIn.
Fantastic. So I just want to encourage everybody out there, whether you're a client or somebody who I've worked with through my LinkedIn space. I mean, Mark is where it's at. He knows what's happening in healthcare. He's super motivating and enthusiastic about his work and passionate and so knowledgeable. I just think what a great guide to all of us in this business. I really appreciate you taking the time out, Mark, to meet with me today.
It's been a pleasure. Thank you so much.
Absolutely. So before we wrap up, Mark, just, one grand finale here, just reflecting on this 37-year career, outside of all the personal changes, right, during that time. Think about it and, just what would you leave us with? What's the message here today that you would want to leave my audience with?
I think it's a message of hope. Healthcare is improving, and there are wonderful, dedicated people in it. We also, as consumers, we know more about health than we did 37 years ago. Right. Every day in the New York Times, the Washington Post, everywhere, there are articles. I just read one on sleep. What do we really know about what's best for sleep, right?
Oh no, sleep.
Right. Something we all need. Yeah. And the great thing about the consumer internet is there's so much information out there. You have to be a good consumer of information because obviously there's disinformation and misinformation. But we have the capability in our modern society to help people live better lives. And I'm thrilled that I've been involved in that just as a journalist, just writing about it, interviewing brilliant people. And it's a good time to be alive in the sense that if you are facing health challenges like chronic illness, there are more tools out there than there ever have been before. So I think I'd like to leave a note of hope for all the challenges that the healthcare system has, for all the challenges that all the people living in the world have. It's a good time in terms of tools and information and leaders who care about you.
Wonderful, wonderful take-home message. Definitely a message of hope and certainly a pleasure. I'm so happy we're working together. Hope we get more chances to do this and having a fantastic day. Thank you so much, Mark.
Thank you.